oxygen delivery goes down. And remember, low oxygen delivery is what we call what? Hypoxia. So one of the causes of hypoxia is what? Hypoxemia, right? If a patient has decreased oxygen delivery to tissue due to low dissolved oxygen, small AO2 is low. We call that hypoxemic hypoxia. Yeah. And they're gonna give you this PaO2, right? They're gonna be giving this PaO2, so you will know if it's low or normal. If it's low, then you're thinking one of these mechanisms that we talked about will be your answer, most likely cause. Yeah. All right. So that's that. What question? What are the things that would decrease bound oxygen? So look at dissolved oxygen. We're still on oxygen content. What do you think would can decrease bound oxygen? The amount of oxygen that is in bound form. Hemoglobin deficiency. Good. Hemoglobin concentration. If it's low, good. That will affect the bound form. And if it's high too, it's going to do the opposite, like polycythemia. The bound fraction will be high. Good. But here we're dealing with hypoxemia. With hypoxia rather, low oxygen. So we want to deal with the low end, right? Not the high end. Good. So if hemoglobin is low, good. That will decrease the bound fraction. And in turn, if bound fraction is low, oxygen content will be low, oxygen delivery will be low, and you can call this anemic hypoxia, right? Anemic hypoxia, because low hemoglobin is anemia. So all the causes of anemia we're going to come across under hematology, or that you know already, right? They can also cause hypoxia, right? Anything that reduces hemoglobin, hemolysis, hemorrhage, iron deficiency, beta thalassemias, megaloblastic, they are all causes of hypoxia. There's low tissue oxygenation. That's why people are tired when they're anemic. Exertional dyspnea, fatigue. Yes, no oxygenation, no ATP, anemic hypoxia. Let's say hemoglobin is normal. Hemoglobin may be normal, right? But the bound fraction is still low. Now you're looking at something affecting what? Saturation of hemoglobin. So hemoglobin is normal, but for some reason, oxygen cannot bind to hemoglobin. And one of the major causes of this is what? Carbon monoxide poisoning. Remember carbon monoxide? Carbon monoxide competes with oxygen for binding site, right, on hemoglobin. Carbon monoxide has about 200 times higher affinity, right, for oxygen than for hemoglobin than oxygen does. So carbon monoxide poisoning will, though the hemoglobin is normal, but still patient will have low oxygen content now because of what? Low oxygen saturation with hemoglobin. Yeah, and with oxygen rather. Low hemoglobin saturation with oxygen. Because carbon monoxide will compete. It's gonna bind to the site and compete with oxygen. So carbon monoxide poisoning. Yeah. Hypoxemia too, right, can affect saturation of hemoglobin. Because how do we load oxygen, right, on hemoglobin? We need pressure. To load oxygen on hemoglobin, you actually need pressure. So if a patient has hypoxemia, right, it can indirectly affect saturation. Yes, we need the pressure generated by PaO2 to load oxygen on hemoglobin. That's why when people have hypoxemic hypoxia, you're also gonna see what? Low SaO2, because the way you measure saturation is what? SaO2 and SpO2. You're gonna be given these. You're gonna be given PaO2, you're gonna be given SaO2 or SpO2. So SaO2, SpO2 is talking about hemoglobin saturation. CBC will tell me about hemoglobin levels to see if they are anemic or not. But SaO2, SpO2 tells about saturation. So in carbon monoxide poisoning, SaO2 will be low, PaO2 will be normal, because there's nothing wrong with the oxygen dissolved form in carbon monoxide. It's the bound form, saturation, and hemoglobin is normal, so the bound form is low, saturation is low, so SaO2 will be low. In carbon monoxide poisoning, SpO2 is normal. If you check oxygen saturation using pulse oximetry, a pulse oximeter cannot differentiate, right, between carbon monoxide and oxygen. So it's misleading. The one that is definitely sure will be what? SA saturation, arterial saturation. SaO2 is better than SpO2. So SpO2 will be low for sure. SaO2 will be low, carbon monoxide poisoning. And then carboxyhemoglobin levels will be high in the blood. That will come from carbon monoxide poisoning. Yeah. In patients with hypoxemia, we already know PaO2 will be low, but then SaO2 will be low too. SaO2 and SpO2 will be low too. Like I said, the PaO2 loads oxygen on hemoglobin. So if there's hypoxemia, PaO2 will be low as well as SaO2. But if it's something just affecting saturation only, there's nothing wrong with dissolved oxygen. PaO2 will be normal, but then SaO2 will be low, like in carbon monoxide, right? Poisoning, yeah. So these are you interpret your labs correctly and just figure out right, where the pathology is. Is it hypoxemia? Is it bound form? If it's the bound form that is low, then look, is it level of hemoglobin or saturation? Hemoglobin is normal, deal with saturation. Hemoglobin is low, then it's like anemia that's causing right, low oxygen content. Yeah. So these are causes of hypoxia by decreasing oxygen content. Any questions so far? Um, okay, so COPD is a type of hypoxemia, right? What is the mechanism of hypoxemia in COPD? Is diffusion problem, diffusion impairment. So they're going to have low PaO2, small AO2. Capital AO2 will be normal, right? Small AO2 will be low. So that's why COPD will have what? Wide AA gradient. And since it's diffusion impairment, they respond right to oxygen. PO2 will increase with oxygen supplementation. But when there's severe obstruction and there's trapping of air, so air comes in, which brings in oxygen, but air can't leave. The air leaving that is trapped is filled with CO2. So that's why you can see what hypercapnia in that case. The CO2 levels in the blood will be high. Then the patient is trapping air, not hypoventilating in this case, unless they are tired, right, from increased work of breathing. But just because on expiration the airways collapse, air is being trapped. The air that is being trapped is actually CO2 that's being trapped. So CO2 in the blood will rise. So you might say hypercapnia, right, in that case. Yeah, clear? Okay. Um, cyanide or cyanide. Cyanide poisoning, right? Cyanide poisoning also causes what? Hypoxia, but we call it cytotoxic hypoxia, right? Cyanide is a little bit different. It's different because the hypoxia in cyanide is not due to anything we have on the board right now. So in patients with cyanide poisoning, their perfusion pressure is normal. We're going to talk about that soon. Perfusion pressure is normal, oxygen content is normal, which means hemoglobin is normal, saturation is normal, PaO2 is normal, dissolvation is normal in cyanide toxicity. The reason is because cyanide doesn't affect any of the parameters here. It actually affects the tissue directly. Tissues are starving, they can't use oxygen, right, in the presence of normal oxygen delivery. So oxygen is there, oxygen is being delivered normally. Oxygen in the blood is normal, but the tissues can't use it because cyanide will inhibit what? The electron transport chain in the mitochondria. That's how cyanide works. Cyanide inhibits electron transport chain in the mitochondria, which allows tissues, right, to use oxygen to make what? ATP. So we call that cytotoxic hypoxia, which means patient is hypoxic, but oxygen content in the blood, right, is fine. So the problem is at the level of the tissue itself, not due to these players, right, that we have on the board. Yeah. All right. So that's cyanide. All right. Before so now let's move on to perfusion pressure. So that's oxygen content. Those are the players. Those are things that can go wrong. So I have oxygen in the blood. I need pressure, right, to get the blood to the tissue, to get the oxygenated blood right to the tissue. What will determine